So yesterday we stopped at this interesting observation with denosumab, with the lumbar spine showing a prolonged increase in bone density with a slope that didn't seem to be slowing down. And that was more or less true for the hip also. And it's rather unprecedented. There isn't any other drug that you know that does this. And the question comes up, well, why would bone density go up inexorably for such a long period of time? And I mentioned the work that David Dempster was involved in which he showed with this triple label approach. These labels are labeling bone their models, their indices of bone formation, and it's a time dependence. That's why they use 3 labels: 6 months, 12 months, 16 months. And what they surfaced or unmasked was in the presence of denosumab, they were seeing evidence for bone modeling, which is kind of unusual in an adult skeleton. We adults don't form bone unless we are stimulated in a very special way. This looks like pediatrics. So how is this? And so the interesting point relates to a secondary effect of denosumab. And in the yellow line is the dose that is used for treatment. It's the 60 milligrams every 6 months. And if you notice the baseline, and up at 1 month, it's about a doubling of parathyroid hormone. And the increase over baseline hangs up for about at least 3 months of the 6 months of the treatment period. And here are the actual data. Over the 3 months, you can see the level is double, more than double, but still double by 3 months. And then it comes down to baseline by the next dose. So for 3 months out of 6 months, PTH levels are higher than baseline. They're not necessarily abnormal, but they're higher than baseline. And this kind of study has been done even as long as 7 years of every 6 months of denosumab use. And so every time a patient gets denosumab, this happens, at least out to 7 years. So it's a repetitive stimulation of parathyroid hormone 3 months out of 6 for at least 7 years. Now, here's the paradox. You know, in hyperparathyroidism, parathyroid hormone levels are associated with a cortical bone disease. In fact, classically, cortical bone density is low. That's why we measure the distal third radius. And it is due to PTH. I mean, we know that. And here we have a drug where there is an increase in PTH, but cortical bone density goes up, right? Non-vertebral bone density goes up, hip density goes up. And so how do you understand this paradox? And so it brings up an interesting possibility related to the 2 pathways of parathyroid hormone action. There are more than 2, but this is the idea. On the right, you have the cyclic AMP rank ligand pathway that is believed to be important for the catabolic effects of parathyroid hormone. Well, if you have denosumab on board, you know what happens to that pathway. It's blocked. So if rank ligand associated bone breakdown is blocked by denosumab, we know that, and yet parathyroid hormone levels are going up, it asks the question, maybe PTH is being shunted into its so-called anabolic pathway, which is on the left. And the anabolic pathway, it takes advantage of Wnt signaling and that sclerostin molecule, which we're going to talk about later. Sclerostin is a brake on Wnt signaling, And one of parathyroid hormone's actions seems to be to block sclerostin. So by blocking sclerostin, it is amplifying the BMP Wnt signaling pathway. So here's the construct. Denosumab is secondarily stimulating parathyroid hormone. You might ask why. I have no idea, although it is possible that there is a subtle drop in the blood calcium. You know, these anti-resorbers are blocking calcium egress from bone. There could be a slight imperceptible, unmeasurable reduction in calcium, and the parathyroid system is so sensitive, PTH goes up. That's plausible. Okay? So anyway, so here's the idea that you're actually having two actions. One, the denosumab effect, and secondly, a anabolic effect by virtue of the secondary stimulation of parathyroid hormone. Okay, so let's take this a little bit further. Let's take one index of cortical bone, cortical porosity, and ask the question, does denosumab affect cortical porosity? And this is work in the monkey, the cynomolgus monkey. And if you overrectomize this monkey, you see a lot of cortical porosity on the right. And if you treat that overrectomized monkey with denosumab, you see much less cortical porosity. So there clearly is evidence that denosumab reduces cortical porosity. So what about the human condition? This was a study associated with the development of denosumab. It wasn't the definitive study. And what it was a head-to-head comparison between denosumab and alendronate with placebo. And it was a short 12-month study. And what we saw was no real change in the alendronate arm, maybe a little bit higher porosity. In the placebo arm, suggestion of even greater porosity. But in the denosumab arm, a suggestion of a reduction in porosity, like the cynomolgus monkey experiment. So we were really intrigued by this observation. If you, on the right, just look at the right, if you correlated the delta change in parathyroid hormone over a range, and this was in naniles of increments, the greater the change in parathyroid hormone in a given patient, the greater the reduction in cortical porosity. On the left, the greater the change in endogenous parathyroid hormone, it happens with alendronate too, but not to the same extent. The greater the increase in cortical porosity, which is what you would expect with parathyroid hormone. So it's a correlation. It doesn't prove anything, but it certainly fits with the hypothesis that the reduction in cortical porosity with denosumab is related to parathyroid hormone. And it could be explained on the basis of that pathway. Ken Poole from England has actually looked at these compartments with QCT imaging of the hip and then doing finite element modeling. And he has shown that the two compartments, trabecular and cortical compartments, both at the spine and at the hip, are increased, suggesting that these changes are associated specifically with increased bone strength. Again, both cortical and trabecular. So with denosumab, and just summarize this, it progressively and significantly increases cortical mass. It increases cortical mass, we think, due to reductions in cortical porosity. The effects on cortical bone may be related to these permissive actions of parathyroid hormone, as it also inhibits rank ligand. And then by finite element modeling, these changes are associated with improvements in strength at cortical and trabecular compartments. So, denosumab seems to be beneficial to both compartments of bone. So we'll take this one more step. Can we correlate these changes in cortical bone with a clinical outcome, namely a reduction in a non-vertebral site? And that would be the wrist. So we conducted another study. It was the Freedom study taken in that extension period. People who had had 3 years of denosumab did not discontinue treatment. The extension study is shown here. The only difference, this was the crossover group. This is the group that got placebo, uninterrupted placebo. 3 years later, you can see the only difference is really they're 3 years older. Their bone density really hasn't changed because they didn't get drug. And what I want you to pay attention to is the placebo group. The placebo group, the radial bone density dropped a little bit, but then with denosumab, as you would now expect, there was a further progression of bone loss was halted. And then in years 3, 4, and 5, you can see that the distal third radial bone density increased and then ultimately reached a level a little bit above baseline. And here again is the placebo, then switching to denosumab. And then if you looked at the relationship between that change and wrist fractures, in the first 3 years, there was no difference from that placebo period in the first 3 years. But in years 4 and 5, when you see the clear reversal and gain of distal radial bone density, you see a marked reduction in the incidence of fracture. So, and here is a sub-analysis looking at this from the point of view of femoral neck T-score. It was only in the group that had T-scores less than -2.5 that you did see this major effect. Okay? So it gives a little bit more credence to the idea that this drug is affecting non-vertebral bone. It is affecting cortical bone strength. And it is not only affecting bone density of the distal third radius, but there may be a clinical outcome, namely a reduction in risk of wrist fracture. Okay, so that's where this is, and it's very interesting as we begin to pay more and more attention to the cortical compartment. This drug seemingly having a rather specific effect there. Now, in terms of side effects, we talked about side effects. I mentioned yesterday in a very well-run clinical trial, what would be the percentage of adverse events you'd expect to see? And we said a perfect trial would have 100%, right? Well, that's pretty good. Look at this, 93%, 92%. Balanced, everybody has a side effect. That's life. But now serious adverse events, as we have defined it, of course, much less, but 25%, 25%. Deaths were matched. Adverse events leading to study discontinuation matched. Adverse events leading to discontinuing study medication also matched. So in that respect, the placebo and the drug groups were not different. Now here are more data related to adverse events of interest, and infection is of interest, and you'll see on average there were infections, but they were balanced. But in terms of skin infections, there was an imbalance, and the group that got denosumab had a significantly greater event rate for eczema. And that has actually held up over time. And again, looking specifically at a skin event and called cellulitis. There were 12 cases in the denosumab group and only 1 case in the placebo group. So 12 to 1 is an imbalance and is significantly different. And in the package insert, it talks about infections. And patients will tell you, oh, doctor, this drug is going to cause cellulitis. You'll notice the word erysipelas. I have never seen erysipelas in adults. It's pediatrics, right? It's beta strep. And so here are adults getting erysipelas. What does this mean? And I have no idea. And there was never any bacteriological proof that this really was erysipelas. So there are some questions about the ascertainment here. But nevertheless, it was recorded as such. The question is this a real concern? And by the way, the cellulitis was easily treated. It was no big deal. Now let me introduce you to one more thing about adverse experiences. I've told you about adverse events. I've told you about serious adverse events, but I haven't told you about adverse reactions. Now, the FDA decided in their wisdom, I don't know how many years ago, that they would have a new category called adverse reactions, and it is the following. Any imbalance between the placebo group and the drug group, numerical imbalance that occurs more frequently, an event occurs more frequently, in the drug arm versus the placebo arm is called an adverse reaction. There is no statistical implication here. If there's an imbalance the other way, there's more events in the placebo group versus the drug group, that's not recorded. So in the package insert of denosumab, you have this table of adverse reactions. And look at them. Look at the top one, back pain. 1,347 examples of back pain versus 1,340. And the package insert actually says the most common adverse reaction in this clinical trial was back pain. So the patient will come to you and say, doctor, I have back pain, or I am prone to back pain. This drug is going to cause back pain. And you need to know what this means. It doesn't mean anything. Now look at the bottom. I had a patient who I thought that denosumab would be good, and she said, doctor, I can't take this medicine. I said, why not? She says, because I've had shingles. I said, okay. And she said, but don't you know this drug causes shingles? And look at this, 79 versus 72, 2% versus 1%. So we're living with this. We're living with this table. And you need to know that it doesn't necessarily mean anything.
So for patients that do have some type of skin issue?
Yeah, good question. If they have a disposition to eczema, I think that is worthy of note. And you might choose not to use it because it could make it worse. I agree with that point. But other than that, even in a patient who's had a history of cellulitis, we don't pay a lot of attention to it. I mean, you could push me a little bit more and say somebody has venous stasis and, they have whatever. I don't know, somebody who has diabetes and a peripheral neuropathy and this and that, more subject to banging their toes and getting foot infections. But let me follow that up, because what I told you about infections has held up with respect to eczema, but not with respect to cellulitis. So here are the summary of this. Serious infections leading to hospitalization were more frequently reported. Serious skin infections more frequently reported. Other small imbalances, ear infections, I think it was 5 to 0. There was endocarditis. I think the score was 3 to 0. These are 8,000 patients we're talking about. 3 cases, but there was a little bit of an imbalance. Endocarditis was rare. And yet there was no increase in opportunistic infections. And that's an important point because this is a drug that interferes with rank ligand. Rank ligand has many, many other influences, particularly on T cell function. So you might worry about somebody who's immunocompromised and on steroids, for example, and yet there was no increase in incidence of opportunistic infections.
And if they have an active infection, will you wait to give them the medication?
Yeah, yes. It's like someone's going to have their teeth extensively fixed. You're going to wait for any of these drugs. Yeah, if they have an active skin infection, you would wait.
What about in HIV patients?
Well, we don't have a lot of experience with HIV, but again, that bottom line would suggest that it would be okay. But everything is relative. You have to, there's no yes or no. Maybe you wouldn't, maybe you would. I have a patient who has HIV for 20 years, actually more than that. He's had it since HIV was first discovered in 1981. Before that, we knew nothing about HIV, by the way. He's lived with his disease in this unbelievable symbiotic relationship. Before we had all the therapies for HIV, he survived the disease, which was fatal. It was uniformly fatal until we got the retroviral treatments. Anyway, and I've treated him with denosumab. He's done beautifully. So it all depends. But the skin thing we emphasize, eczema we emphasize, but it isn't something that has been seen with prolonged use of denosumab. The first 3 years, that clinical trial did show that imbalance, but 7 years of greater experience has now not confirmed that there's an imbalance in skin infections. That is, the incidence of skin infections dropped in the next 7 years to the same level of the placebo of the first 3 years. Okay. But there is another point to talk about, and that is the very powerful effect of this drug. This is actually much more powerful than the bisphosphonates in terms of their effects on bone turnover. The histomorphometry showed eroded surface, which is a marker of bone resorption, was 80% reduced. 50% of the bone biopsies had no osteoclasts whatsoever, gone. And then in terms of double labels, which you'd expect as a marker of bone formation, only 20% of those individuals had evidence for double labels versus 90-95% of the placebo group, or the group that got alendronate in another study, that head-to-head study. And bone formation rate also can be measured by dynamic histomorphometry, was markedly reduced. So this drug really affects bone turnover. Yet, there was no difference in these parameters, lamellar bone, mineralization, the amount of osteoid, and these trabecular indices were actually not different in the DMAP group versus placebo. So yeah, it profoundly affects bone turnover, but from a structural point of view, it doesn't seem to be negative. But the FDA in 2010 noted the skin infection point and did also note the suppression of bone turnover. Now, the further information, which I alluded to a moment ago, suggests that this skin worry is probably not as much of a worry. The next 2 years of the study, looking at the incidence of eczema, infections, and cellulitis, the only area where there was still an imbalance was eczema. In terms of infections overall, 1.4% versus the placebo rate of 1.4%. And then the cellulitis or erysipelas category, it fell to less than 0.1 in the next 2 years, similar to the very low rate that was seen in the placebo group. And even further, the study has gone into 3 years, and then there's more data suggesting that these imbalances that were present in the first 3 years have really come back to what would be the placebo rate, the left column versus the far right column, as I've outlined. Really, we're not seeing it. And from an anecdotal point of view, you know, we've had the drug now for 6 years. I haven't seen anything. I haven't seen any skin infections. And we use a lot of denosumab here. So I think this whole thing is out there. You can't ignore it, but we appreciate that. It's like what we talked about yesterday in terms of ONJ and atypical fractures. There's so much hype about this when, in fact, there's very, very little data to make you really concerned. And then the last point about the suppression of bone turnover had to do with follow-up biopsies after those biopsies showed marked suppression. And these were 2 studies. You know about Freedom. The STAND study was the head-to-head with alendronate. And this study took advantage of stopping denosumab and then rebiopsying individuals anywhere from the end of study to 3 years later, and looking at recovery of some of these suppressed features. Very small number of subjects, only 15. But again, in terms of the histology on the second biopsy, you can see that lamellar bone, normal mineralization seen in all subjects. And then now you're seeing double label in 93%, 14 out of 15. So the system comes back. The system comes back very, very rapidly. And here's another example of how rapidly the system comes back. If you look at CTX or P1NP in the post-treatment period in the purple, these bone turnover markers really shoot right back up, which makes a very important point, and that is if you stop denosumab, it's very different from stopping bisphosphonate. There's a reversibility. In fact, let me make a more general comment. The only class of drugs for which we don't see reversibility are the bisphosphonates. Every other drug you know of, including estrogen, there's a rapid reversibility of the effect. And this is not an exception. The bisphosphonates are the exception. So you need to think about this. If you're going to stop drug, or your patient doesn't come back for her 6-month injection, things are going to go in the other direction. Compliance is very important. And if you choose, for whatever reason, to stop denosumab after whatever period of time you want to stop it, you can't just stop it. Cold turkey doesn't work. You have to replace it with another treatment if you don't want patients to experience not only a reversal by virtue of bone turnover markers, but a rapid reduction in bone density. That will happen. And here are the reversibility data in more dynamic terms. You know, within a year of stopping denosumab, CTX not only gets back to baseline, but overshoots, and bone density falls. And then when you restart after that 1 year, you, of course, return the marker back down to that very low level, and bone density starts to come up. So that's not good. You don't want to be playing. It's a moving target. So I don't like the idea of stopping denosumab, but you do have to worry because if prolonged treatment may be associated with some of the things that we've talked about, and it has been associated with ONJ and with atypical fractures. We have no idea whether it's more or less because we have much less experience with denosumab. Another thing about denosumab you have to know about is whether or not it can be used with CKD. We know about the bisphosphonates, the relative or absolute contraindication. Zoledronic acid you don't use if the clearance is less than 35 cc's a minute. And the other bisphosphonates you're very careful if the clearance drops below 30. Now with denosumab, however, the situation is quite different. This was a sub-analysis of the Freedom trial, looking at individuals who had these different stages of CKD. And across the board, it didn't matter what the clearance was. There was a reduction in new vertebral fractures in every case.
Were these patients biopsied first to know what kind of CKD?
No, they were. No,
had?
they were just. There was just an estimated clearance. What do you mean by biopsy? What would? No, this was just estimated creatinine clearance.
To know if they had a dynamic bone disease
Mm.
versus.
No idea. No idea. We don't know. You're asking what kind of, what underlying bone disease did they have as a function of their CK? I have no idea. This was not part of it. But the point was that whatever, whether or not it wasn't, didn't seem to, you saw uniform effects across the board. Creatinine levels didn't change, and there were no other indices of problems in this group. So, fracture risk reduction and changes in bone density at all sites were in favor of DMAB over placebo at all levels of renal function, and the treatment efficacy did not differ by renal function. Again, there were no important differences in creatinine and calcium, which leads us to say that this is a really very attractive drug in people who have renal insufficiency. You don't have to adjust the dose, but there's one caveat, and that is those individuals whose vitamin D is low and whose serum calcium may be low normal as a function of renal disease. In the clinical trial, I was the head of the Data and Safety Monitoring Board, so we saw all this data. The only patients we saw who developed hypocalcemia were these people, the ones who had levels of 25-hydroxyvitamin D that were low, and those whose serum calcium was kind of low normal. If you see that, beware. And I don't give denosumab in patients who have 25-hydroxy levels less than 20. I first replete them, and then I give them denosumab. So I want them up to 30 before I'm going to give denosumab, even if they don't have renal failure. I just want to be sure that I'm not going to get into trouble. So that's a little bit of a caveat in terms of when you would use denosumab in these settings, and then make sure that you fixed the problem if you can before you use it. In terms of O&J, there were 4 cases. 2 in subjects who had taken it continuously for 6 years, but a couple who had been in the placebo group, and then soon after they started denosumab. So this time dependence of O&J is really not as clear as we used to think it was. To a certain extent, it's related to time on therapy, but not only. And then atypical fractures have also been described. Okay, just a comment on androgen deprivation therapy. This has been studied and published in the New England Journal. Men being treated for prostate cancer. This was an interesting study looking at DMAB and placebo over a 3-year period. And you can see that over the 3-year period, there were significant reductions in new vertebral fractures. So in this special group of men who are getting ADT, in whom bone density is going to fall, DMAB seemed to be very efficacious. And actually as efficacious on the right versus the Freedom study in terms of the relative risk reduction of new vertebral fractures. This study with ADT seemed to show that it was just as effective as the Freedom study. And then in terms of infections and such, there were no differences. Again, not supporting the idea that these people are at greater risk. Okay? So that is a whirlwind tour of denosumab. Now, we're going to another area. And yeah.
I have a question about this denosumab. What about combination with the other biological therapy like rituximab and rheumatoid?
Got it. Hold it. Hold that question. It says combination therapy. It's coming.
And when do you decide reclass versus DMAP? Like, what patients are you?
Well, that's a very, very important question that has no answer. They're both wonderful drugs. They're obviously different drugs. They're both extremely convenient, once a year and once every 6 months. They both require a visit to a doctor or a healthcare professional or a facility. DMAP is not self-administered. It's not like Teriparatide. There are things to consider. What's the patient's renal function, as a case in point. There's a lot of individuality. Some patients who have already read about both of these drugs will say, "Doctor, I'm never going to take that drug, but I'll take this drug." I can't give you a good recipe. There isn't any real 1, 2, 3. I'm going to use reclass 1, 2, 3. I'm not. I saw a patient yesterday who has been on 2 years of teriparatide, and she did very, very well. And I decided to go with zoledronic acid, which seems to be standard. Felicia loves this. Give a shot of Zol. Done. Finished. But I'm sorry, I can't answer your question any more than that. It's really very, to a certain extent, very subjective. Yeah.
The PTH elevation that you see with denosumab, is it continuous or is it pulsatile? Like, with the first 3 months?
That's a good question. I don't know. It's a good question. Nobody's looked at that. Yeah, whether that increase is the same whether there's the same physiological dynamic as we see in regular people. It's a good question. I'm sure no one has looked at that.
Have you seen the same elevation of the PTH with biphosphonates?
Yes.
And where does
But not to the same extent. So the alendronate, there's actually a published paper with alendronate. Bone PTH goes up 30%, and then it comes down to a level that's barely above the baseline, 5%, 10%. So it does go up. It will go up. Anytime you perturb the calcium, which is probably going to happen, even though you can't measure it, PTH will go up. But it's a different, because of this idea, it's not necessarily going to help the bisphosphonate, because when PTH goes up, it's still going to be able to use both pathways. It's only in the context of denosumab where PTH goes up and it cannot use that rank ligand pathway. So it seems to be a beneficial element of DMAB, but not necessarily a beneficial element of alendronate. Again, it's not pulsatile. It's a up and a down. Okay? All right. So we're moving on to another class. And let me introduce you to the enzyme cathepsin K. It is a very important enzyme of the osteoclast. And it is a protease, so it breaks down collagen. So as part of the initiation of the bone remodeling unit, cathepsin K is secreted into the bone matrix, and collagen is digested, and you have this little hole. And cathepsin K, by the way, is ubiquitous. It's everywhere. And the various cathepsins are cell-specific. Cathepsin K seems to be found a lot in osteoclasts. It's found a lot in lung, and it's found a lot in skin. And this brings up the question of spillover effects. Are there potentially off-target effects of a drug that would inhibit osteoclast cathepsin K if there's overlap between pulmonary and skin? The obvious thought here is to develop an anti-cathepsin K as a treatment for osteoporosis. And the attractive idea here is if you have a specific inhibitor of cathepsin K, you will not necessarily kill the osteoclast. Very different from the mechanism of action of denosumab or the bisphosphonates, where those agents literally destroy the cell. This drug inhibits an enzyme of the cell, but not the cell itself. In fact, in animal studies with the anti-cathepsin K, there are more osteoclasts, many, many more osteoclasts in someone who's being treated with the cathepsin K inhibitor than someone who isn't. So, what is the disease associated with cathepsin K deficiency? It's called pycnodysostoses. So you pediatricians, have you ever seen pycnodysostoses? It's really rare. Talk about rare diseases. I've never seen pycnodysostoses. All I know is how to pronounce it. This is the famous artist, Toulouse-Lautrec, who people think may have had pycnodysostoses. Of course, nobody knows, but he looks like he might have. It's a high bone mass syndrome because this is a genetic deficiency of cathepsin K. And they don't particularly do well. There are animal models in which cathepsin K is knocked out, and you see, excuse me, a high bone mass phenotype. And there are models where you overexpress cathepsin K, and you then activate the osteoclast and would expect the opposite, a high turnover state. So the phase 2 trial with the drug is called odanacatab. ODAN, by the way, ODAN, O-D-A-N, is a tribute to the person I mentioned before who picked alendronate out of the basket of potential bisphosphonates, and that was Gideon Rodin. And so Gideon, they didn't call it rodanacatab. That would be too obvious. So they took the R off, but the ODAN is a sort of a remembrance of Gideon. And this is the last cathepsin K standing, as we say, because the other cathepsin K inhibitors had those crossover effects. They either caused or seemed to induce a pulmonary fibrosis, or there were morphia-like effects on skin. So despite the fact that there have been a number of CAT-K inhibitors in development, this one is the one that is far advanced, and I'll tell you where we are with the CAT-K inhibitor, odanacatab. So this was a dose-ranging study. And you can see the typical phase 2, placebo and out to 50 milligrams. This is an oral drug given 50 milligrams because of the dosing, the study that I'm going to tell you about, once a week. So it's pretty easy. And the data showed at that 50 milligrams a week, very similar now to denosumab, bone density in the lumbar spine and femoral neck goes up and doesn't seem to plateau. That's another, there's a second drug that may have a more prolonged effect on bone density than the drugs we're used to. Now, it should be an anti-resorber. It's blocking an osteoclast. So on the left, are our friends, 2 resorption markers, urinary NTX, serum CTX, and not really in a dose-related fashion, although allegedly it is. There is a reduction in bone resorption as monitored by these 2 resorption markers. On the right, you see a little different pattern. And only at the 50 milligram dose do you see a modest reduction in these 2 bone formation markers. So we're not seeing the linkage that we typically expect, with the bone formation markers falling not quite to the same degree, but much more so than you're seeing here. So let me illustrate that a little better for you. Here's alendronate and here's denosumab. In the orange is the inhibition of bone resorption, and in the yellow is the inhibition of bone formation. And as we now expect, both sides of the linked system are damped, but the resorption is damped to a greater degree, and the balance is now altered in favor of better bone balance. In the case of odanacatinib, you have a similar reduction in bone resorption, but not much in terms of bone formation. So you can think about this, and maybe this drug would be more successful in altering the balance in favor of improved bone balance. The other thing, which is very interesting, has to do with the presence of the osteoclast. It's not dead. In fact, there are many, many osteoclasts in the presence of odanacatinib. And they're functional, except that they can't make or express cathepsin K because it's all tied up. So the thinking here is that the osteoclast continues to signal to its partner, the osteoblast, by various signaling molecules, and we don't really know which ones these are. And these signals, going back to the osteoblast, may sustain that part of the partnership, so that the bone remodeling system is not shut down to the same extent as it is with the bisphosphonates or with denosumab. So now let me bring you up to date on the phase 3 clinical trial. It was completed in the year 2012. That's 4 years ago. The data are being presented ASBMR in 2014, and there is a paper describing it last year. There are two discussions to have. One is efficacy, and the other is safety. So this was a randomized, placebo-controlled, double-blind, event-driven trial, 50 milligrams weekly, with the primary endpoints being new morphometric fractures, hip fractures, clinical non-vert fractures, and then a bunch of secondary endpoints, as you can see. The average age of subjects was 73. Again, you're familiar with this now. They had osteoporosis either by bone density or by having evidence for a radiographic vertebral fracture. This is the largest of the osteoporosis studies that we have had, almost double the studies you've seen before. 16,000 subjects, almost 400 centers, and 40 countries. Can you imagine how much this study cost? Take a guess. Take a guess. You have any idea? I mean, it's got to be at least $1 billion. At least $1 billion. And the study was very successful. A good majority of the subjects completed the study. And the results are quite amazing. 54% relative risk reduction of new and worsening morphometric vertebral fractures, 47% reduction in clinical hip fractures. It's all significant. Reductions in clinical non-vert and clinical vertebral fractures. Across the board, wonderful efficacy data. Now, you might wonder, if that's so great, why is it 4 years later and the data have not yet been submitted to the FDA for review? And it, of course, has to do with safety. Not this issue, not the morphea-like skin lesions. There were lesions seen, and significantly more so in the odanocative group. So morphea adjudicated as morphea-like, only on the trunk, but never on the face so far. And interestingly, not associated with any systemic sclerosis or something you might expect with morphea. And also interestingly, reversible. So when the drug was stopped, including, as we've been told, the placebo group, there were 3 patients in the placebo group. When the placebo was stopped, it's kind of interesting, there was a reversal. Now, some of these people were treated with steroids. I mean, it's a mixed bag. So we really don't know. But this was not a permanent effect at the skin. So that's of note. No pulmonary issues as far as has been reported. But there were atypical fractures seen. 5 in the odanocative group and none in the placebo group. And to my knowledge, there wasn't any cases of O&J. So all these anti-resorptives seem to be associated with these rare events. Certainly not a unique feature of the bisphosphonates. And again, we can't compare because we don't know. No differences in systemic sclerosis, serious respiratory infections, or delayed fracture, no O&J. The last bullet is the one that is still up for discussion. There were numerical imbalances in some of the MACE endpoints, atrial fibrillation, major cardiovascular events, and deaths, strokes, et cetera. And the imbalance, although not statistically significant, was evident. And so, what happened, or what has happened, is a agreement between the company and the FDA to re-adjudicate these cardiovascular endpoints by finding the many subjects who were not part of the final analysis, which is a lot of people. So around the world, there is this effort to find these people who are in this trial and try to determine whether or not any of these events happened or not. And this has taken a lot of time. We hear something every month. Next month, the next month, the next month. We now hear that this year we will have that re-adjudication, and then the company is planning to submit to the FDA. So that's it. Stay tuned.
Why did so many people drop out?
Well, it wasn't that so many people dropped out. It was that they had 16,000 people. So I think they had 80% compliance, so 20% of 16,000 is a lot of people. And I don't really know about how the different sites, whether they collected the data as completely as was expected. There were, I'm not part of this trial. I can't give you too much more information, but there was the concern that there was an ascertainment bias in the way the data were collected that put the drug in an unfavorable light. But if the complete data set were available, it might or might not. That's the statement. And who knows? We'll see. Okay, we're moving to another topic. Well, anyway, odanocatab is a very interesting drug, and if things go well, it will be available in the next year or so. All right, let's move on to anti-resorptives, and not anti-resorptives, the other, the osteoanabolics. So here's the idea, that you have a very bad structural entity in the bottom, and you would like to improve the microstructure of bone. And I like to say that some of us who like to dream, maybe it's possible to cure this disease. Can you completely reconstruct the skeleton? And that is sort of the holy grail, and we're not there yet, but we're making progress. So it is a discussion now of the osteoanabolics. I use the term osteoanabolic because if I say anabolic, those of you who are into the sports world will say, oh, they're on drugs. We're giving our patients anabolic. No, osteoanabolics, drugs that build bone. And the two we're going to talk about are Teriparatide, which all of you know something about, and Abaloparatide, about which I bet none of you know anything about, or maybe some of you do, but it's a new osteoanabolic. So let's go back to our friend, parathyroid hormone. All roads lead to parathyroid hormone. And the drug that is available for the treatment of osteoporosis is that foreshortened fragment PTH 1 to 34, very discovered very serendipitously, as I mentioned last week, just laboriously looking at what was the minimum residue length that gave you the classical actions of parathyroid hormone. And in those days, it was much harder to make PTH 1 to 84. Now it's easy, but in those days it wasn't. So 1 to 34 became the fragment that people used both experimentally and then ultimately to develop a drug for osteoporosis. But the central question is, how can a hormone that's bad for bones be good for bones? Doesn't make any sense. Hyperparathyroidism is bad for bones. Dr. Silverberg probably told you that. And this is the famous sea captain, Charles Martel, on the left, and 4 years later on the right, 1929 to 1933. This disease, hyperparathyroidism, will potentially destroy the skeleton. Now, of course, we don't see that phenotype anymore, or very rarely. Actually, we do see this phenotype, but it's not common. And yet, we say it's good for bones. So what's the trick here? And the trick is the way you administer the drug. If you give it intermittently, and this is a rat study, 1 hour per day versus 24 hours per day, and then look histomorphometrically at the osteoblast or the osteoclast, you see that the intermittent administration in the blue preferentially stimulates bone formation, while the continuous administration on the right in the pink preferentially stimulates bone resorption. This was the clue that the way you administer parathyroid hormone may influence profoundly what effect the drug or the hormone has. Continuous administration is a catabolic experience, while the use of same molecule and a low dose gives you the osteoanabolic effect. So this suggests, as I've mentioned before, that PTH has two pathways, a catabolic pathway and an anabolic pathway. And in the low dose situation, given intermittently, the anabolic pathway is favored, and I've shown you this before. It's the anti-sclerostin pathway that seems to be tweaked and stimulated when low dose PTH is given in the manner that we do with teriparatide. What does teriparatide do? It stimulates bone turnover. It increases bone size and shape. It improves microstructure. It reduces mineralization. And it increases bone density. It does it in a very interesting way. And Bob Lindsay published this paper years and years ago. And I think it's really important because it fits with a hypothesis And it goes this way, that the initial effect of teriparatide in the orange is to stimulate bone formation. Later, at some time, the same agent stimulates bone turnover, bone resorption. And there is a window of time during which you're going to see primarily bone formation. Now that, if you believe this, suggests that the classical bone remodeling unit, which requires activation of the osteoclast, is not initially stimulated by teriparatide, but rather, going back to this idea of modeling, the initial actions of this drug are to stimulate bone formation on quiescent surfaces, namely to stimulate bone modeling. And here's my cartoon that has been dubbed the Bilzekian cartoon. Even those who disagree with this call it the Bilzekian cartoon. So this is either being kind to me or not being kind to me. But here's the idea. Bone formation is stimulated, followed by bone resorption, and you'll notice that this graph, which has no time dimension by numbers, eventually there's a downturn in bone resorption and bone formation. This is a biological fact. It had nothing to do with the FDA's restriction on the use of teriparatide for 2 years. The FDA unwittingly understood this, that there is a limit to the actions of teriparatide. It has nothing to do with the worries about osteosarcoma. If you give teriparatide for long enough, which is somewhere around 2 years for most people, you will lose the effect of drug. Okay. But during this period, particularly before bone resorption kicks in, you have what we have called the anabolic window, when the actions of teriparatide are maximally anabolic. There is histomorphometric evidence from David Dempster and our group to support this idea. So it's not just bone markers. Okay, so teriparatide in postmenopausal women. Bob Neer was the principal author. Bob Neer gave a wonderful talk last week at the National Osteoporosis Foundation meeting on the development of teriparatide. And it went through some rocky courses. But in the end, of course, it turned out to be quite successful. The initial clinical trial was designed to be 3 years, but it was only 19 months in duration. And that is because of the osteosarcoma data that became available then, osteosarcoma in rats. A very small study, and not as big in terms of countries as the other ones I've talked about. Of course, this is a very old study. It's almost 20 years old when it was started. There were 3 arms: placebo, 20 micrograms, that's the dose we use, and then they'd used a higher dose, 40 mics. And the endpoints were vertebral, non-vertebral fractures, bone density, bone markers, and the median treatment was 21 months, again, planned to be 36 months. And here are the data. New vertebral fractures reduced by a lot, and non-vertebral fractures also reduced by a lot. We don't have hip data because, again, this is a very small study, and it was only 19 months, 21 months. So you wouldn't expect to have hip fracture data, and we don't have it. And the data show, as I mentioned, the reduction in non-vert fracture is effective in women with mild or severe previous fractures, effective in women with 1, 2, or more, and Mike McClung and Paul Miller have published on a reduction in complaints of back pain. So, works. And again, This is the kind of data you get by bone biopsy. We published this with David Dempster. The company has also their own data. But this is what happens. You have not just filling in of the trabecular compartment, but you actually have improvement in the cortical compartment as well. So this is the first drug where we can talk about true microstructural reconstruction. The other drugs strengthen bone by other means, but they don't actually improve microstructure. So who gets this drug? The FDA says advanced osteoporosis at high risk for fracture. It's not a first-line agent unless people meet this criteria. So what do you mean by high risk for fracture? Well, some of you may say very low T-score. I would accept that. I don't know what do you mean by low T-score. It may not be the same thing as what I mean by T-score. But less than -3 is low. So you could say somebody whose T-score is -3 meets your definition of high risk for fracture. Somebody who's -3 and older, age being an independent determinant of fracture risk, -3 at 70 is much worse than -3 at 50. So you might say, okay, age might feed into your thoughts. And of course, someone who's had a previous fragility fracture, that easy in terms of a definition, that really places somebody at high risk because that we know the next fracture is not far behind. You have to know this, and you have to be prepared to argue because this is a very expensive drug. On the street, it's about $15,000 a year, over $1,000 a month. And coverage is not always guaranteed. So you have to make the case, and then if your patient's claim is denied, as an advocate for your patient, you have to get on the phone, you have to write, and you have to know why you're prescribing teriparatide. So you might also think about teriparatide in someone who's being treated with an anti-resorptive and who has a fracture. Now, it doesn't mean that the drug is a failure. Fractures occur with any drug you use. But operationally, you could say it's drug failure. Patient has a fracture on a drug, you could call it a drug failure, and you could certainly reasonably consider teriparatide. Not everybody does well with these drugs for one reason or another. Maybe they're not taking it. Maybe they're not absorbing. The bisphosphonates are absorbed 0.6% of the administered dose. That's a very small absorption efficiency. And maybe somebody just doesn't, absorb the drug enough, or for whatever reason, the patient is not responding. The issue of intolerance, GI particularly, may be an issue. And then, so you can broaden your indications. And then you need to know when you wouldn't use this drug. Children, we don't use it in children with open epiphyses. We don't use it in anyone who has a history of osteosarcoma. Paget's disease of bone, which is a risk factor for osteosarcoma. X-ray treatment to the skeleton, someone who has breast cancer and has been treated with RT, which would include the ribs, you don't use. So that would be what I just said. Hyperparathyroidism, or any condition in which there is either a high PTH or hypercalcemia. Obviously, you're not going to use teriparatide. Pregnancy, we wouldn't use it in pregnancy. And metastatic disease to bone worries me because of particularly the diseases like breast cancer and prostate cancer in which there's an osteoanabolic effect of the cancer. And that could just fuel the whole thing. We know PTH stimulates IGF-1 and such, so you could make things worse, theoretically. So these are situations where you would not use teriparatide, even if otherwise the criteria would be met. So where are we with this whole issue of the black box? It's a black box drug. And the reason why it's a black box drug is because of the animal toxicity. If you give this drug to rats, and not just the Fisher 344 rat, but any rat, give it in doses that are pretty high, 3 to 60 times the human equivalent, and give it for the 2 years period. A rat lives for 2 years, 2.5 years. So for most of a rat's life, by 18 months, you'll start to see osteosarcoma, both in the female and the male rats. And at the end of the 24 months, about 50% of the rats will have osteosarcoma. So there's absolutely no doubt that this drug is very bad for rats. No doubt. When these data became available, the drug company, of course, was in a total panic. They stopped the clinical trial. They convened a bunch of us, so we flew to Indianapolis and found about this. And very interestingly, all of us felt that this was not going to pan out as a human toxicity. And also interestingly, the FDA did not tell the company to stop the trial. But the company stopped the trial. They're out of here. And they said, this is it. This is the end of the drug. And we asked what would be the conditions under which you would submit the data for approval, given this animal toxicity. And they said, well, if the efficacy data blew your socks off, you know, unbelievably efficacy, yeah, then we would do it. And of course, when they interpreted the data, only the 19-month data now, I showed you the data, they said, well, let's go for it. So they did go for it, and they got approved with the black box warning. We are now 14 years, yeah, just about 14 years. The drug was approved on November 26th, year 2002. So we're coming up to 14 years. We have an experience with teriparatide that amounts to over 2 million people worldwide have been treated with drug. Granted, only a 2-year exposure. We understand that. But so far, there have been no human signals at all. What I mean by human signals is that there have been a handful of cases of osteosarcoma in people who have been exposed to teriparatide. And the numbers of subjects who have developed osteosarcoma, those numbers are much smaller than what you would expect based on the epidemiology of osteosarcoma in adults, like 1 in 250,000. So no signals there. In terms of the drug registry, the osteosarcoma, I don't mean drug registry, I mean disease registry, the paper by Andrews reviewed over a 7-year period all the osteosarcoma cases in the country in this registry. And there were 1,500 cases. They were able to survey half of them. And no subject who, in this country who got osteosarcoma had any history of being exposed to teriparatide. So that's where we are. But if you ask me, is this a reason to be concerned? No. No, and you have to discuss with your patient what I just told you. Treatment is limited to 2 years. That's what the FDA says, and why they said it, I think, has to do with the rat toxicity over that 2-year period. But 2 years of a rat's life is like 75 years of our life. So lifelong exposure. 2 years is not lifelong exposure to us. Nevertheless, that 2-year proscription, it might also be the case that the drug was only studied for 19 months, and the FDA is wary of extending period of treatment beyond the clinical trials. But on the other hand, this is the only drug that has a time limit in our field. The drug has to be kept refrigerated. I saw a patient yesterday who, for reasons I won't get into, and I won't say this too loudly because I'll say this carefully. Anyway, I procured for her 2 months of teriparatide from my fridge, gave it to her. I gave her the cold pack. She's staying at a very, very fancy hotel downtown. She has a refrigerator in her hotel, in her suite. She's taking it immediately to her hotel, and then she'll arrange for the airplane that she'll be on to keep it cold. And she goes, you have to go through hoops because it has to be refrigerated. So that's a negative. And it is expensive. All right, so that's teriparatide. Yeah.
Have you ever given it for 2 years, not given it for 5 years, and then
Yeah.
repeated it?
Well, yeah. So your question is 2 years, do something else, and then, oh, by the way, you do have to do something else because we and others have shown that, again, like all these other drugs, if you stop, there'll be a reversal of the effect. And then retreat. No, I've never done that. I have had experiences of, hey, bless you, continuing the PTH, the teriparatide, for more than 2 years in the days when we could do that. It was easier to do in the old days. Dr. Cosman has published on different ways. She's published on a study of 1 year and then off 1 year and then retreatment for a year. She's also looked at another system, another way of doing it would be 3 months on, 3 months off, and then intermittently using a bisphosphonate. So you drug, bisphosphonate, 3 months on, 3 months off. And she's sort of shown like a stepwise improvement in bone density. The problem with all these variations on the theme is that there are no data. There are no data of fracture efficacy, so you're really using it off-label. And I don't think that's a good idea, so I don't take liberties. The only liberty I might take would be to try to extend the treatment period, but that's very difficult to do because of the issue of the insurance coverage. But I don't like to manipulate on, off, because we really don't know the data.
In patients who have a history of lung cancer or breast cancer but no radiation, they've had chemo and surgery, do you get a bone scan to rule out mets, or do you just?
You can. I wouldn't give it anybody. I wouldn't give it to anybody who has a recent history of breast cancer. If you told me it was 20 years ago, but then I worry too because breast cancer has a way of coming back 20 years later. So even without X-ray treatment, breast cancer has that. Not all breast cancers that are metastatic to bone are blastic, but there are. So I worry about that in particular, and I worry about prostate cancer, even though in breast they may not have had X-ray treatment. But it's it's one of these things. You have to balance risk. Maybe she's at such risk for fracture. There are people, who are really at risk, and you say, look, let's go for it. Okay, so let's go on to another very interesting molecule. And we're only going to talk about the top one, a PTHrP analog. Now, let me describe what this molecule is. It's called abaloparatide. In green, on the top is the just a schematic of teriparatide. In the middle is PTHrP 1 to 34. And the green are the areas of homology with teriparatide. So the first 34 amino acids have some sequence homology, particularly the first 15 amino acids. Abaloparatide is identical to PTHrP out to residue 21, right? They're all they match up completely. Beyond residue 21 or so, you see the yellow cassettes. Those are residues that have been empirically inserted into the carboxy terminal end of the amino terminal fragment, PTHrP 1 to 34. And the idea was to have a molecule that would have a very transient affinity for the PTHrP receptor, a fleeting moment of interaction, exploiting the idea that the quicker the hit with PTH, the better the effect. The PTH-PTHRP receptor has a much more stable configuration. And if that molecule were to bind to that more stable configuration, it would be the opposite of what you're looking for a drug to treat osteoporosis. It would be perfect as a drug that you would be looking for to treat hypoparathyroidism. The longer acting PTH is what would be hoping. So this was a very ingenious invention of a molecule that would have a quick interaction and then be off the receptor. That is the drug, abaloparatide. The phase 3 trial ended in September 2014. The results were available in December, and Paul Miller has presented on the data March of the past 2 years. The pivotal trial results are in review by JAMA right now, and there's an extension to this trial that has just been submitted to JCM. So here's the phase 3 trial. The blinded part of this trial is placebo and abaloparatide. Notice that abaloparatide is used as 80 micrograms, 4 times the teriparatide dose. If you used 80 micrograms of teriparatide, everyone would be hypercalcemic. But the drug is designed to be more anabolic. So more calcium is going to go into bone and would mitigate the tendency for hypercalcemia. The open label was the last arm. The teriparatide was not blinded. Those who got teriparatide knew they were getting teriparatide. So the third arm was open label. And here are the data with regard to bone turnover. In the green is teriparatide. In the orange is abaloparatide. In the blue is placebo. And what you see is what you might have wanted to see. A lesser effect on the left of abalo to stimulate bone resorption, but a similar effect, not too different, of abalo's effect to stimulate bone formation, as seen by P1NP. And yet, in terms of bone density, not much of a difference in the lumbar spine. Both have showing good accrual of bone density. And on the right, not much of a difference in terms of the incidence of new vertebral fractures. Actually, quite a remarkable 80% reduction, both with abalo and with teriparatide. In terms of hip bone density, both total hip and femoral neck, now you see abalo having a little bit of an edge, but perhaps more importantly, the time course of increment at the total hip and at the femoral neck seems to be moved ahead by about 6 months. So it seems to maybe improve bone density faster and maybe a little bit more than with teriparatide. In terms of non-vertebral fracture and clinical fracture, there is a 43-45% reduction with abaloparatide. And it is significant by placebo, not different with terms of teriparatide. The differentiating feature of abaloparatide might rest in this time course. This Kaplan-Meier curve suggests that the effect on non-vertebral fractures is very, very fast. While the differentiation between teriparatide and placebo, those top 2 curves, you don't see separation until about 1 year or more. And if this holds up, this would be very interesting, because we've talked about how difficult it is to show non-vert fracture efficacy. And when you do see it, it usually takes longer because of the fact that bone turnover is so much slower. In terms of clinical fractures, most clinical fractures are non-vert fractures. Again, you see an early separation between abaloparatide and the placebo and the teriparatide curve. So it's possible that this drug is going to show be advantageous in this regard. The drug does not have to be refrigerated. You can put it in your pocket and take it off. So that's another potential advantage. And another potential advantage is shown here. The ultradistal radial bone density seems to go up quite remarkably with abaloparatide, not any change with teriparatide. And on the right, there's a huge reduction in wrist fracture incidence, while there's no reduction. And those of you who have used teriparatide and have monitored distal third radial bone density, it always goes down. In fact, a lot of doctors say, I don't want to measure distal third radius with teriparatide because everybody gets upset. Doesn't mean it's bad, it's just that it changes bone density, but it does improve microstructure in cortical bone. But here, there might be a point. So, abaloparatide was submitted to the European Agency for review in November of 2015 and to the US FDA on March 30th of this year. So this year, we will hear from the EMA in Europe, and we will hear from the FDA about whether it's going to be recommended for approval. And it looks good. Does it cause osteosarcoma in rats? It does. Will it get a black box warning? Who knows? This may be an opportunity to take off the black box warning of teriparatide. I think there's a discussion about this. We'll see.
What is the expense differential?
No idea. Expensive?
Right.
I have no idea. Yeah, they never tell you that. Is it going to be expensive? I mean, yeah, it's going to be expensive.
I mean, like compared to teriparatide.
I have no idea. I have no idea. They don't talk about that. I will tell you an interesting story. Years and years ago, when the company that sells teriparatide, they made a U.S. tour. They went to 50 of the top thought leaders, and they spent about an hour with each of us, asking us a lot of questions about where we felt teriparatide would fit in the menu of drugs available for osteoporosis. In those days, it was just bisphosphonates, raloxifene, and estrogen. One of the questions they asked was, what would you think we should peg the price of the drug at? And we all, very interestingly, pegged it at about twice the going rate of the bisphosphonates in those days. And they thanked us very much for that advice. And the number that we had suggested, they tripled.
Do you always check P1NP after you start teriparatide?
Not anymore. Not anymore. I used to. But you know, the only reason for doing that would be on in those unusual cases where patients aren't responding. There are patients who don't respond. In people who have been on a bisphosphonate and then are switched to teriparatide, there will be a delay in these effects I mentioned, and the delay could be as much as 6 months. So you wouldn't worry. If someone's on alendronate and you switch them to teriparatide, there may be no change in the markers for 6 months. But for someone who hasn't been on a previous treatment, I don't do it initially. I will do it 1 year later, because I like to mark that to see how they're doing, but I don't do it quickly. I don't see any real need for it. Okay. Mohammed, you're on. You want to give this talk? We're going to take a break in a minute because my voice is falling apart, but it'll last. It'll last another hour and 15 minutes. I decided I can't talk for a day anymore. I used to be able to talk all day. My voice is changing. I have to, but that's all right. We're managing. Okay, we're going to talk about combination therapy, the combination we're going to talk about is teriparatide and denosumab, because all the other studies that have used teriparatide and zoledronic acid and the other bisphosphonates, they've really been underwhelming. I don't really like to use combination therapy of those combos, but this one is very interesting. And there's a reason why it's very interesting. And it has to do with the rationale for using a rank ligand inhibitor and teriparatide. And you know what you can even give me the rationale now, because I've already told you about it earlier. Denosumab inhibits rank ligand. The dual actions of teriparatide to increase bone turnover will be preferentially directed to bone formation when rank ligand is inhibited. It follows very logically this scheme that now we're talking about exogenous PTH, not endogenous, and we're going to see maybe further effect because you're utilizing the Wnt signaling pathway more preferentially than it would be if you were not using the combination therapy. It's very much consistent with what I told you earlier about the endogenous increase in PTH with DMAP. So the work has been done by Ben Leader and Joy Tsai at the Mass General. They published a number of papers now with this combination. And what you see in the top panel, the top lines, graphs, at the spine and at the hip regions is a significantly greater improvement in bone density at the lumbar spine and hip with combination therapy than with monotherapy of DMAP or teriparatide alone. And Joy has gone on to use HRPQCT and has shown in some trabecular and cortical parameters, not all of them, more so in the tibia than in the radius, that the combination is better by virtue of a greater change from baseline. And in some cases, the inter-arm comparison showed significant differences. So from a densitometric point of view and from a microarchitectural point of view, there seem to be advantages. However, only, and I have to change that slide. It's DMAP, but it's also true for the bisphosphonates. We only have these surrogate markers. We don't have fracture data. We don't have long-term data. And very limited data on bone quality. And remember, using two drugs adds to expense, and it adds to the potential of side effects. So I'm not advocating that we should use combination therapy, but if you were to be thinking about combination therapy, I think the use of teriparatide and DMAP would be on the top of my list. Okay. So, crystal ball. There is yet another class of agents that are being developed. And again, like pycnodysostoses, the clue comes from human diseases, rare diseases, sclerosteosis and Van Boeken's disease. These two diseases are almost unique to the Dutch population. The Dutch population in South Africa and the Dutch population off an island in the Netherlands that's been isolated for years and years and years. And these two diseases, they're a little bit different. They're both homozygous diseases. They have to do with a mutation in the sclerostin gene. They're in different locations of the sclerostin gene. But what it is a sclerostin deficiency disease. Now, knowing what we know about sclerostin, which regulates the osteoanabolic pathway, Wnt, if you block sclerostin, you amplify the anabolic pathway. Just like if you block osteoprotogerin, you would block the rank ligand pathway. You would stimulate the rank ligand pathway. So these are high bone mass diseases. Bone mass is increased throughout the skeleton, and these people never fracture. They never fracture. They get into big trouble, but they never fracture. They get into big trouble because they have bone overgrowth. So the neurological foramina just are closed off, so they have huge neurological issues. More so with sclerosis than with Van Boeken's disease. But the clue was that inhibit sclerostin and you improve bone mass. A further clue was the fact that the heterozygote carriers have one copy of the gene, the defective gene, so they have half the concentration of sclerostin, have high bone density also. They are bone forming, the markers of bone formation are up, and they don't have those neurological sequelae, and they don't break their bones either. So, what would you like to do? You would like to develop a drug that would be an anti-sclerostin. Now, this isn't showing up well. I don't know, it's not, this computer didn't pick up, but you'll see what I'm trying to illustrate. You see Wnt up there, sclerostin up there. Another inhibitor of Wnt is DKK1. You have LRP5, 6, LRB4. And what the pathway, how the pathway works is that Wnt engages with its receptor, LRP5 and 6. And by engaging that system, it blocks a cytoplasmic enzyme, GSK3 beta, which ordinarily metabolizes beta-catenin in the cytoplasm. By blocking that enzyme, you allow beta-catenin to gain entry into the nucleus of the cell, where it serves as a transcription factor for osteoanabolic actions. That is the way the system operates. Sclerostin interposes itself at that receptor level, LRP5/6, preventing Wnt from gaining easy access. And by that means, beta-catenin is degraded into the cytoplasm and is restricted into its pathway to the nucleus. So here is another one of these balancing acts. The balance between sclerostin and Wnt at this receptor level may carry the day as far as how much bone formation you're seeing or not. Okay? So an anti-sclerostin would facilitate this Wnt signaling pathway. And here indeed is the idea. The sclerostin antibody, as it circulates, will tie up sclerostin and then allow Wnt to merrily come along, engage with its receptor system, block GSK3 beta, and then sclerostin and beta-catenin gets into the nucleus. That's the idea. And the animal studies showed that this anti-sclerostin antibody has a profound effect in terms of the overectomized animal, marked increase in periosteal bone formation, endocortical bone formation, osteoblast surface over bone surface, as well as the three cortical envelopes, the periosteal, endocortical, and intracortical. The green shows this profound effect to improve these compartments. And interestingly and surprisingly, not stimulating osteoclasts. That is really interesting because one would have expected, again, as we know, you stimulate bone formation, you stimulate bone resorption. Teriparatide does that. But not this drug. There is an inhibition or a reduction in osteoclasts. So this is almost the perfect combination therapy wrapped up in one drug. A drug that stimulates bone formation and inhibits bone resorption at the same time. And getting back to our idea of bone modeling, these are cynomolgus monkey data. after 10 weeks of this sclerostin antibody, you see the entire surface in the panels with sclerostin antibody literally covered with label. This is not bone remodeling. This has got to be a modeling effect. This anti-sclerostin antibody is allowing the adult to act like a child, to grow bone. Again, a really interesting exploitation of the potential of the adult human skeleton to model itself. Now, the drug I'm going to tell you about is romosozumab. I'm not going to talk about blozozumab. But romosozumab is the anti-sclerostin antibody. Mike McClung has published the phase 2 data, excuse me, of a small study with a dosing regimen that's complicated. But the dose that is being studied in the phase 3 trial is the 210 milligram dose given subcutaneously every month. The 210 milligram dose, right now, the formulation requires 3 injections. 70 milligrams, 70 milligrams, 70 milligrams. 1, 2, 3. Yeah, a bother. Maybe they can do better. The primary endpoint of the phase 2 trial was a change in bone density at the lumbar spine. And here are the data. 1 year later, an 11.3% increase in lumbar spine bone density. The comparators are teriparatide and alendronate, and you can see they don't come close, either at the lumbar spine or at the total hip. And the further experience with continued romosozumab gives you a 15% improvement after only 24 months. Now, with denosumab, we saw, what, a 19% improvement over 10 years. This is a 15% improvement over 24 months. And that translates into 1.5 T-scores. In 2 years, you can go from a T-score of minus 2.5 to a T-score that's normal, minus 1. And which brings up a rhetorical question or statement. Be careful what you wish for. A powerful anti-sclerostin agent that stimulates bone modeling without any control because resorption is not regulating it. It sounds like the rat, doesn't it? Sounds like the rat. So, the clinical trial bore that in mind. This is the bone turnover markers. Bone formation goes up. Look at how it goes down, though. It doesn't stay up. The body doesn't like to be continually stimulated. And the resorption marker, CDX, drops, comes back to baseline, and then drifts down a little bit. The clinical trial, recognizing this very powerful effect of romosozumab, went this way. 1 year of Romo, followed by 1 year of DMAB. Only 1 year of Romo. I thought that was very smart. And the placebo arm had 1 year of placebo followed by 1 year of denosumab. Okay? So you've got 1 year of Romo, 1 year of DMAB, and then the comparator is placebo, and then a denosumab control. The 2 primary endpoints were vert fractures at 12 months and 24 months, and non-vert fractures at 12 and 24 months. That was a very ambitious goal, to think that you could affect non-vert fractures in 1 year. Very ambitious. The phase 3 trial announcement was February of this year. And it was a press release. We have nothing else but a press release. The 2 primary endpoints were met. 73% reduction in vert fractures at 12 months, 75% reduction in vert fractures at 24 months. But the secondary endpoints were not met. there was no significant difference in non-vertebral fractures, either at 12 months or 24 months. So we have a very interesting drug exploiting a very important mechanism, not showing, by virtue of the way the study was designed, the broad spectrum efficacy that we want to see. And I have nothing more to say about that. I don't know what's going to happen. Yeah.
Just to clarify with the two primary endpoints, so if they're saying 73% reduction at the first year and 75% after that, are they saying there's only a 2% reduction between the next year?
It was not. It was from baseline. Yeah, it was not. No, the study was not designed to see a further significant difference between 1 year and 2 year. It was at baseline to 1 year, baseline to 2 years. So there's no difference between 73% and 75%.
So would that possibly suggest that really you're getting the most benefit from that first year?
Yeah, it suggests that it's the ROMO, and the DMAB is just whatever.
Did they do rat studies looking for osteosarcoma?
Yeah, are there rat studies looking for osteosarcoma? I don't have any information about that. I don't know. That's a very good question. I can't answer it. I don't know. I don't have any idea whether they've looked at it.
Presumably the FDA would want to know the answer.
All right, we're going to take a break, but I want to just finish up. Believe it or not, my time management has been pretty good. We've done this for eight hours, and we're only 1 minute late. So this is the summary of therapies and their mechanisms. Bisphosphonates are anti-osteoclasts. They work by farnesyl pyrophosphate synthase, and they have broad spectrum efficacy. Raloxifene is the SERM, certainly vertebral, but we don't have evidence for the other sites. Similarly with calcitonin, which we haven't talked about. DMAB as an anti-rank ligand inhibitor drug blocks, has efficacy everywhere. Teriparatide, stimulating bone formation to a greater degree than bone resorption. We have evidence for efficacy at vert and non-vert, but not at hip. Albaloparatide has a much bigger differential between osteoblast stimulation and osteoclast stimulation. Similar spectrum with teriparatide, but perhaps a faster time course. And finally, ROMO as an anti-sclerostin drug. At the moment, we have evidence just for vertebral fracture. And again, looking at these drugs as classes, the anti-remodeling agents inhibit resorption to a greater extent than formation. Cathepsin K is in a different ballpark because it minimally affects bone formation. The osteoanabolics stimulating formation more than resorption. And then the drug, the anti-sclerostin, stimulating formation and probably not very much in terms of bone for resorption. So here's my crystal ball for the future. These are the drugs we have in the United States now. Strontium is not one of our drugs, of course, but calcitonin is. But if you look at the whole spectrum, what I think is going to happen in the next 5 years, and we did not talk about calcitonin or strontium, but because of worrisome side effects, either real, perceived, or based on epidemiology, my crystal ball says those two drugs are out. We're not going to have them in the next 5 years anywhere in the world. But instead, we're going to have two more classes, if you will, this special PTH class, that analog of PTHRP, and the anti-sclerostin molecule. And then on the anti-resorptive side, we're going to probably have at least one cathepsin K inhibitor. All right? So new insights into bone biology have led to new therapeutic approaches. It's wonderful how we've been able to exploit these pathways on either side of the coin to gain not just new insights, but new therapeutics. And I think we're going to learn more. I think this is just the beginning of new knowledge. So some people think the glass is half empty, and others think that the glass is half full. And since you've gotten to know me a little bit over the past 2 weeks, you know what kind of a guy I am. It's half full. So this is my prediction for the future. My dear friend Mike McClung took this slide and said, the future is sunny with clouds.